First of all, I'm highly thankful to Orlando Diabetes 2022 for inviting me as a keynote address for my topic, which is blood sugar fasting, blood sugar, postprandial blood sugar, and glycosylated hemoglobin estimation level and their correlation in the management of the diabetes. Management, we need diagnosis and treatment both of the diabetes. As everybody knows, diabetes mellitus is a group of metabolic disorders due to hyperglycemia, and etiopathogenesis of this hyperglycemia is either decreased insulin secretion or this excessive production of glucose. Everybody knows that type of diabetes is type 1, type 2 based on etiopathogenesis, and the gestational diabetes and diabetes due to other causes, that is maturity onset diabetes of young, diabetes associated with genetic disorders, and diabetes due to drug induced and associated with other endocrinal disorders like acromegaly or Cushing syndrome. Why we are talking too much about diabetes is that this is the most common, widespread, rapidly spreading, worldwide spreading metabolic disorder. In 1995, there are 150 million total diabetic patients among the common population of the world. And what is projected now is that by 2025, it will be going to be 300 million, just double in last 30 years. Not only this, the incidence is also increasing, previously limited to developed country. It is increasing also in developing countries. And 1/3 of the patient, when they are diagnosed diabetes, they remain undiagnosed for so many years until they develop symptoms. And incidence above age of 40, pre-diabetic and diabetic are found to be 24%. Not only this, the magnitude of the problem. Problem is that the diabetes mellitus is a progressive disorder and it is lifelong lasting. And as it disease progress, complications of diabetes also progress, like stroke, myocardial infarction, congestive heart failure, chronic renal disease, chronic renal failure, sudden cardiac death, and out of 50% of cardiac death, 50% found to be diabetic. And out of renal failure, who died of renal failure, 80% are non-diabetic. In my own country is going to be very soon diabetic capital of the world. So this is the magnitude of the problem. Nowadays, the previously designed etiopathogenesis diagnosis and of the diabetes is obsolete, type 1 and type 2. And previously we said type 1, those who required insulin for the whole life and early onset. And type 2, we say those who are hypoglycemic above 40 years and need oral hypoglycemic agent. This theory has been obsolete. Nowadays, management of diabetes depend upon the history of diabetes and the progress of the diabetes. And type 1 diabetes is a progressive disorder, and there's no pre-diabetic state in type 1 diabetes. There's non-diabetic, it goes directly to full-blown diabetic, and many times present with diabetic ketoacidosis first time. Secondly, the age was a factor. Now maturity onset of diabetes, maturity onset diabetes of young adult need insulin from the very first day. Secondly, type 2 diabetes also require insulin. So now it is not known as insulin dependent diabetes or non-insulin dependent diabetes. So type 2 diabetes is divided into normal, non-diabetic, or it's a pre-diabetic, and diabetic with 3 stages. Not requiring insulin, early stages, may require insulin for control sometimes, and in the end stage require insulin for can be managed with their cause. Suppose gestational diabetes is a temporary diabetes, is revert back to normal after delivery. Same time thing, type 2 diabetes, pre-diabetic state is reversible. If we find out pre-diabetic state patient is obese or having metabolic syndrome, with the lifestyle changes, it can be reverted back to non-diabetic state. So we can reduce the incidence of the diabetes. And as the time progresses, the disease progress in all the type of diabetes. We are having three markers for diabetes: fasting blood glucose level, 2-hour postprandial blood glucose level, and glycosylated hemoglobin estimation. Previously, past we are doing 75 gram glucose estimation, 2-hour glucose estimation. Later on, we was doing glucose challenge test, in which after 1 hour see the highest level of the glucose. These two tests are now obsolete because for screening of the program, and when doing in large group, these tests are not possible. So now we are going with the fasting blood glucose level. If it is less than 100 milligram per deciliter, then it is normal. And postprandial blood glucose level after 2 hours 140 milligram per deciliter, then it is normal. And HbA1c level less than 5.6, patient is not suffering from diabetes. For the pre-diabetes, is blood sugar fasting level, if it is 100 to 125 milligram and postprandial 140 to 199 milligram per deciliter, and HbA1c level 5.7 to 6.4%. 6.4% is a cutoff limit which is set. We are following the American Diabetic Association, recommended by American Diabetic Association. And for the full-fledged diabetes, if fasting blood sugar is more than 126, postprandial blood glucose level more than 200, and HbA1c level is more than 6.5, then patient is having diabetes. So aim of screening is early detection of the pre-diabetic patient and metabolic syndrome, lifestyle changes, and revert back to non-diabetic. So it will reduce rapidly progressing incidence of the disease, can be reduced worldwide. So large number of screening should be done. Second, large number of individuals diagnosed type 2 diabetes are asymptomatic for so many years, and they are unaware that they are suffering from this disorder. So HbA1c screening test among the diabetic population reflect the compliance of the drug, and not only the progress of the disease, diagnosis of the disease, it also shows the how much disease is progressing. And if the percentage or number of patients with more than 7% of the HbA1c level give the good idea about efficacy of the treatment, and ideally for the prevention of the complication, HbA1c level should be kept below 7%. So objective of this study was early diagnosis of the diabetes, and crucially important for reduction of the complication, reducing the incidence of diabetes in the community. Second, HbA1c is an accurate marker of screening of early detection of pre-diabetic and diabetes from the normal population. And in this study, the association between the fasting blood glucose level and HbA1c level was assessed through the cross-sectional population study. Then why we have taken these two markers? Because postprandial is not possible estimation when we do a large study. Second, if we are taking independently accurate marker of fasting blood glucose, is having its disadvantage that it estimates the blood glucose level at a one time in 124 hours at a given time, that is exactly 10 hours after fasting. So it can be done only once. HbA1c can be done throughout the day, but it is having disadvantage that if there is anemia or hemoglobinopathies, the reading of HbA1c is wrong. Secondly, there is some variation, racial difference of HbA1c is also reported many times. So when we combine together as a marker of fasting blood glucose level and HbA1c level together for screening and management of diabetes, found to be more important. In my study, I conducted the two studies, that is study number 1 and study number 2. Because I conducted two studies, one is urban area, the study number 1, and study number 2 in the rural area. Because in my country, the incidence of diabetes is different. It is higher in urban area and lower in the rural area. So study number 1, in which I've taken 100 patients from urban area for a reputed lab. Randomly, I selected them, those who came for irrespective of age and sex, those who came for executive health checkup, or they came for annual health checkup. And annual health checkup also patient opted are usually those who are having already hypertension or they suspect they are having diabetes, or they are having other risk factor, obese, they came for executive health checkup. Persons of the community who do not think that, or most of the time think healthy, they do not come up for the routine executive health checkup yearly. So we have taken 100 patients in this. In study number 2, we have conducted in the rural area, in which 125 people are gathered in the rural area with prior notification for the diabetes and hypertension awareness program, and testing for HbA1c and fasting blood sugar at the same time with a strict method. So here also the patient who came turn out, those who suspect diabetic or who are already having diabetes or hypertension, they turn out more. And what was the result? Study number 1, out of 100 patients between age minimum of 13 years and maximum were 85 years, 54 were male and 46 were female. 44 people are already suffering from diabetes and 25 are pre-diabetic, and only 31 are found to be non-diabetic. But study number 2, which is conducted in the rural area, out of 125 persons, minimum age 24 years and maximum age found to be 75 years, 84 are male and 41 are female. Out of 125, 84 are found to be diabetic, 17 found to be non-diabetic, and 19 are pre-diabetic. And even in 84 diabetic patients, 61 patients are having HbA1c level more than 7%. That is 75% patients who are suffering from diabetes are having uncontrolled diabetes and having more prone for complications. So when we, for the correlation, what is the HbA1c level and fasting blood glucose level correlation graph in the rural area, we find a linear curve with green one are non-diabetic, blue one are pre-diabetic, and red are diabetic. It shows a linear curve. And similarly, correlation graph for urban area within fasting and blood HbA1c level, again green one is non-diabetic, blue are pre-diabetic, and red are diabetic. It also shows the linear curve. Then we done the rural data analysis for HbA1c level more than 6.5% and sensitivity and specificity of fasting blood glucose level against the glycosylate hemoglobin in diabetes with more than 6.5% rural camp, and we divided into confusion matrix, and we divided into 4 categories. First one, patient have high fasting blood glucose level and HbA1c level positive. This is a true positive. If person is having HbA1c level positive but fasting blood glucose is normal, then false positive. Person is having a HbA1c level negative but fasting blood glucose is raised, then false negative. And persons are having both fasting blood glucose level and HbA1c both are negative, they are non-diabetic. So divided into 4 categories, and what we found, the accuracy is 86%, sensitivity is 82%, and specificity of the test is 100%, and positive predictive value 100%, negative predictive value 64%, and balance accuracy, which is the sensitivity and specificity combination of both divided by 2, found to be 91%, which is quite significant. Similarly, with the correlation of the fasting blood glucose level with HbA1c level in rural camps, what we found, age, there's no correlation with the age, there's no correlation with the gender, but fasting blood glucose level independent have a number 1, and HbA1c level independent is 0.99. Combined both is 1. Similarly, respective p-value of the correlation for the gender, age is 0, for gender it is 0, but fasting blood glucose level 0.97% and HbA1c level is 0.95%. Combining together, the p-value came out to be 1.67. That is quite significant. Similarly, confidence interval of the correlation When with the age and gender, there's no correlation between age and gender. There's no correlation between age and fasting blood glucose level. Similarly, age and high HbA1c level is a slight correlation where the age increases. There correlation is better with the HbA1c level, and with the gender, male or female, there's no relation with the fasting blood glucose level. And gender with HbA1c, there's no correlation. But fasting blood glucose level with HbA1c level, the correlation R value is 0.9% and P value is 1.67%, which is quite significant. Reporting correlation in APA significant, but with the fasting blood glucose level 0.25 and HbA1c level 0.25, and combining together it came out to be 1. So combination of fasting plus HbA1c have a significant value. Similar study and specificity and data analysis we done in a urban data analysis, in which again HbA1c level more than 6.5%, and we construct the sensitivity and specificity of fasting blood glucose level against the HbA1c level in diabetes in the health checkup program. And here again we divide into confusion matrix for fasting: true positive 29, false positive 1, true negative 10, and true positive 60. Accuracy found to be 89%, sensitivity 96%, and balance accuracy is 91%, which is quite significant. And correlation of fasting blood glucose with HbA1c level in herbal health checkup: age, there is no correlation; gender, there is no correlation, but fasting blood glucose level 0.24 and HbA1c level 0.21, and combined both is 69, or HbA1c level is 1. Confidence interval of the correlation: age and gender, R value and P value, there is no correlation. Fasting blood glucose level with the age is P value, is no correlation. Age with HbA1c level, there is no correlation. Gender with HbA1c, fasting blood glucose level and HbA1c level, there is no correlation. But fasting blood glucose level with HbA1c level, it is 0.85, which is significant. And respective P value for the correlation: for the age it is 0, for gender it is 0, fasting blood glucose level having significance, and HbA1c there is significant value is 29. And reporting correlation of the APA table style: age is very less, gender 0.50, very less, fasting blood glucose level when compared is -24, and HbA1c level -21. Combining together, that is 79 and 90, average is 85%. That is quite significant. So conclusion of the study is that association between HbA1c level and fasting blood glucose level is relatively stronger among diabetics than non-diabetics. Secondly, fasting blood glucose level was a more accurate predictor for HbA1c level compared with HbA1c level as a predictor for fasting blood glucose level. Biggest hurdle in this study was varying cutoff point for HbA1c level. Some people keep at 6%. Minimum level is fixed 5.7% for HbA1c everywhere, but cutoff limit is 6% somewhere. This is 6.5% by American Diabetic Association. In UK study, it is 6.2%. Plus age come out to be 12%. Otherwise, if we keep 6.5, it is coming to be 24%. So this is the difference depending on the pre-diabetic level. HbA1c level is accurate marker for screening of diabetes and differentiating pre-diabetics and diabetics from the general population. Together, combined with fasting blood glucose level, give more better result. But HbA1c level alone is not only for prevention of diabetes, it also prevents the complications of diabetes. It is kept below 7%, so progress and complications of diabetes is not there. So take home message is that fasting blood glucose level combining with the HbA1c level are the accurate marker, are the most promising for diagnosis of disease and management of the disease. Thank you very much.